My assignment today is conotruncal abnormalities, and I hope I'll try to do justice. I'll give you a brief about what is conotruncal abnormality. It is conus, which is the infundibulum, and the truncus, which is the common arterial trunk, and we combine the abnormalities which happen in this area. We call it conotruncal abnormalities. There are so many common things in this conotruncal abnormalities. One, they are high genetic association. There is a higher chance than other abnormalities for an extra cardiac abnormalities. Most of these would have a normal four-chamber view, and being difficult to diagnose, the accuracy of diagnosis even today is about 70%. The concept of the conus, we born with conus under both the great arteries, under the aorta and under the pulmonary artery, and both arteries originally arise from the right ventricle. So we are born with a situation like DORV, and over a period of embryogenesis, the conus of the aorta is absorbed, and aorta falls inferiorly and to the left because of loss of conus and gets connected to the left ventricle, and the conus of pulmonary artery is retained and it connects to the right ventricle. While in case the conus of the pulmonary artery gets disappeared, absorbed, and then it would connect to the left ventricle because it moves inferiorly and to the left, and the conus of the right ventricle is maintained, so connects to the right ventricle. If both the coni are absorbed, and then it leads to a very rare condition, but it does exist, called double outlet left ventricle. Both great arteries actually fall inferiorly and connect to the left ventricle. Very important thing here to recognize that most of these conotruncal abnormalities, they arise from migration of cells from the neural crest, and that's the reason they are more commonly associated with genetic abnormalities, with the thymus abnormality, and with extra cardiac abnormalities. So now, apart from the conus and what I showed you, there is a truncal valve, which is a spiral valve which divides aorta and pulmonary artery. So if this does not work well, we lead to a condition called common arterial trunk. Enough of embryology, sir. I am going to discuss about how to arrive at a diagnosis in a conotruncal abnormality, would share with you tips and tricks, and would discuss the differential diagnosis. From there on, it's more important, which I'm going to focus, is what are the factors which impact the outcome of the neonate and what surgery is required in conotruncal abnormality. This is something critical for you to understand, to have a data to give an informed counseling based on what information you have. And in conotruncal abnormalities, I don't think so I'll be able to do justice by doing all the conotruncal abnormalities. So maybe if time permits, I would, but I think I'll focus till then into a tetralogy of Fallot and TGA, which are fairly common disorders. So let me begin with the tetralogy of Fallot, short from called TOF. Actually, it's monology, and why I'm sharing this with you, because this has an important bearing on the implication of surgery after the birth. It indicates the severity, and how does it manifest is that you have an ventricle septal defect. Tetralogy, 4 components. Component 1 is ventricle septal defect. Number 2 is overriding of an aorta. Number 3 component is pulmonary stenosis, and number 4 component is right ventricular hypertrophy. The last one doesn't happen in the fetus, so we have 3 components. Actually, it's a single component. You would notice in this video the conus moves towards anteriorly and towards the pulmonary artery, making it narrow. And when it moves rightwards and to anteriorly, it leads that aorta overrides the ventricular septal defect. So this is what happens. The conus moves or infundibular moves to the rightwards anteriorly, making pulmonary artery small and allowing aorta to override on the ventricular septal. So this is the single abnormality which explains all four components, and I'm again showing in this cartoon. You can see the movement of the conus or infundibular septum rightwards and anteriorly, making the pulmonary artery small. More shift of conus towards the right side, smaller is the pulmonary artery and larger is the override of the aorta on the interventricular septum. So now this is important. More conal shift, severer is the tetralogy of Fallot. That's what one must understand before we go ahead on imaging. So degree of this thing decides whether the patient is a pink tetralogy, is a less of cyanosis, if the shift is less, and in case the conal truncal shift is more, it would cause a profound or a severe uh, desaturation because of severity of the tetralogy of Fallot. To begin imaging, you should see that this is a large perimembranous ventricular septal defect, and you can see the aorta is overriding it, and this override is about 50%. It's lying right in the middle of the the ventricular septal defect. That is the hallmark of tetralogy of Fallot. The very first thing what you should look for, is there any override of an aorta? And once it's overriding, obviously the blood from both right ventricle and left ventricle would enter the aorta. Now the second component, one is override, second component is small pulmonary artery. Now in this video of a three vessel view, you see this is superior vena cava, this is the trachea, and you have a aorta which is larger than pulmonary artery, and PA is about 60% of that of an aorta. So this indicates what? This indicates pulmonary stenosis. Now another component to it, which again comes to your observation, that pulmonary artery normally through ductus connects to the aorta and forms a V on a three vessel view. But in tetralogy of Fallot, when the pulmonary artery is stenosed, is smaller, it connects somewhere in the middle, so it doesn't form a V but instead forms a T. That's another clue to the diagnosis of tetralogy of Fallot. So this is basics of tetralogy of Fallot, and you can also observe in these three-dimensional echoes that right ventricle and left ventricle, they have a large VSD, and there is a aorta which is overriding. Because majority of the blood now is going through aorta than the pulmonary artery, the aorta is generally larger than pulmonary artery, and it's larger even than normal. So this is an overriding of aorta with the flow across it. Now I am going to show you the shades of severity of tetralogy of Fallot, and let's go through it. Number one is, once you have the aorta which is overriding by about 20% only, this it is 20% of aorta is going up to the right ventricle. Rest mainly it's coming out of the left ventricle, so we call it 20% override of aorta. So that means the override of aorta is less because of what? Because of less shift of the conal septum or infundibular septum. Again, because of that, the pulmonary artery is not very small. It is just about 20% smaller than the aorta. So this would lead to a child with a lesser cyanosis, and we can call this as a pink Fallot. The saturation may be nearly normal. So it's a milder form of tetralogy of Fallot. Now I take you another side of the spectrum where it's a severer form, the severest form of tetralogy of Fallot. Now in this you can notice there is aortic override. You can see the blood flowing from LV and RV into aorta, but what is glaring is on a three vessel view, you can see a reversal of flow in the pulmonary artery. Now, reversal indicates the less forward flow, indicates a very severe pulmonary stenosis. And look at the pulmonary artery filling retrogradely. And this is one of the marker that this child, while on the day one, also can have a problem because of it is ductal dependent circulation. The pulmonary artery is filling from the ductus. If ductus closes, the pulmonary artery flow would be jeopardized. Another patient of similar nature, aortic override with the flow from both ventricle into aorta, and then you see the pulmonary artery. At the first look of it, pulmonary artery doesn't look that bad. It looks at least 50% of size of the aorta. But once you put the color Doppler on, you see in the pulmonary artery both blue and the red color. The red color indicates that the blood is moving this side, and that is coming from the ductus. So this blood is that there is a ductal reversal of flow and some antegrade flow, right? So this is somewhere in the middle, but still because the flow is coming from the ductus, it's highly likely that this child, when it born, can have a problem which could be duct dependent. Before I move ahead and show you various parameters for an assessment of severity of tetralogy of Fallot, you must know what surgery we do. Now, and that again is important for you to tell the patient during your counseling session. The best surgery is that we open small area of the right ventricle, we open pulmonary artery, we put a patch, dilate pulmonary artery, and leave the pulmonary valve intact, right? That's very important. And then you approach, do not cut the right ventricle, approach from the right atrium and close a VSD. Okay, this is ideal. And what is the requirement? Pulmonary artery size should be adequate. Pulmonary valve size should be adequate. In case pulmonary valve is not of an adequate size or pulmonary artery is not of an adequate size, we are left with no choice than to cut the pulmonary valve open and cut through the right ventricle. So this cutting and sparing, not sparing the pulmonary valve would damage the pulmonary valve permanently. And this can lead to a problem after a decade of surgery of the pulmonary arteries. If the pulmonary artery is small in a tetralogy of Fallot, you can suggest your patient during counseling that it's likely the child would require multiple surgeries and can have a problem after when the child is about 10 to 20 years of age, would have a problem related with absent pulmonary valve which has been dissected during surgery. In case the pulmonary artery is very small, we need to do a palliative surgery, what we call as a shunt from the aorta to the pulmonary artery, so that the pulmonary arteries grow to an adequate size so that this kind of surgery, corrective surgery, can be performed. Meaning that we would need two surgeries or a staged surgery and tetralogy of Fallot. This is becoming uncommon in current scenario, but still does happen. So this kind of patient, you have to tell the patient that child may require staged two surgeries in case the pulmonary artery is very, very small or there is a pulmonary atresia. So that is why we need to make an assessment of the pulmonary artery and make an assessment of severity of tetralogy of Fallot. And these are the parameters which we need to make a severity. And out of this, the most important being pulmonary valve annulus, aortic annulus. And if we can do that, and this is based on these views, inside to inside edge, we take various dimensions and we put these dimensions together to make an assessment that what is the severity of tetralogy of Fallot. And this is how we do it. This is an aorta where you make an assessment. This is the pulmonary artery and pulmonary annulus, and that is branching of the pulmonary artery. And you can take right pulmonary artery diameters here, and that's how we take the diameter in real life. And these are the various parameters which you may or may not remember right now. I have a YouTube channel, it's very easy to remember, Echo and Sing. Echo Sing is the channel where I have described all that, and you can actually go there and refresh your knowledge. Same, use two ratios. I think I would not delve into this for a longer time. and you can go to my YouTube so that channel and see that video there. So cardiac counseling based on the data what we have, delivery, normal obstetric indications, the place of delivery can be done in anywhere, but in cases where you have requirement of urgent pediatric care should be done in a tertiary care unit. And what are the situations? That is a critical pulmonary stenosis, or there is a pulmonary atresia and the duct dependent circulation where the child might crash in the first few hours of birth. Another situation I must mention where the child can have a problem in early neonatal period, and that problem is that in case you have an absent pulmonary valve, in the absent pulmonary valve there is a severe pulmonary regurgitation, but at the narrow of the pulmonary annulus you have a pulmonary stenosis apart from other features of tetralogy of Fallot. And what it leads to? It leads to dilatation, marked dilatation, or doubling or tripling the size of the pulmonary arteries, which actually end up compressing the bronchioles, and it leads to bronchomalacia in the beginning of the child in the neonatal period, can create a problem with the respiratory issue. So this child also ideally should be delivered in the tertiary care unit. Then another thing what we need to see is this, what I am showing you in absent pulmonary valve. You have this large pulmonary artery, this is the right ventricle, and then there is a to and fro blood across the pulmonary valve. The pulmonary valve is missing here. Okay, you don't see a pulmonary valve, and this is what is tetralogy of Fallot with absent pulmonary valve. So that was that, and let's come down to another abnormality, fairly common, is the transposition of great arteries. What is transposition of great arteries? To understand the basics, the blood from the deoxygenated blood from IVC, SVC, vena cava comes to RA and RV and goes to aorta back, and then from there again to IVC, SVC. So this blood never sees lungs and remains desaturated, but the blood on the left side comes from the pulmonary vein into, and you have the pulmonary artery coming off to the left ventricle, and then the pulmonary veins are draining here. So now this goes back to the lung, and this blood which is oxygenated never happens to see the circulation systemic one. That's what is on fetal echo. You see LV and you see the pulmonary artery arising there, branching, and aorta arising from the right ventricle. What are the various steps or features or which can suggest TGA? Now, the very important thing is that once you have an aorta coming from the left ventricle, it goes anteriorly and to the right, while the pulmonary artery arising from the right ventricle goes posteriorly and to the left, and they cross each other right angle to each other. This is what we call as an arterial crossover. So if outflows they cross each other, this rules out transposition of great arteries. While in the TGA, what you get is that you get the pulmonary artery coming from the left ventricle and it dips down, and aorta coming from right ventricle also dips down. There is nothing which goes anteriorly, so that means both vessels are parallel to each other, they don't cross. And that's what you see on this echo, that you have a left ventricle pulmonary artery branching, and you see the pulmonary artery dipping straight posteriorly, and that's the reason you see it. Now, we now understand that the vessel coming from the right ventricle is large and it arches anteriorly, superiorly. This is the right, this is aorta. And the branch which comes from the left ventricle is smaller, it branches and goes posteriorly. So that's pulmonary artery. Another way, another parameter of this thing is parallel vessels. As the outflows do not cross, the vessels go parallel with each other. That's the pulmonary artery, that's an aorta. Another parallel vessels, the best way to see the parallel vessel is a four-chamber view or a lateral four-chamber view or apical four-chamber view, which is slightly tilted. This is not a normal four-chamber view or normal LVOT view where you would see this. and then same the parallel vessels you can see. Then there is a single vessel in 3VT, single artery. Single artery means that this is an aorta. That in TGA, the aorta and pulmonary artery, they lie superior inferiorly, they don't cross each other. So once you have a section of your ultrasound passing through the aorta, you'll see a single vessel, you won't see pulmonary artery. Once you have the section passing through the pulmonary artery, then you won't see an aorta, you just see a pulmonary artery. So you see a single artery in three vessel view. That is a very important clue to diagnosis of transposition of great arteries. Now, if you see on three vessel view a single artery, there's other artery is missing. What is the differential here? Differential is then you move to see, do you see parallel vessels in outflow? If yes or if no. If yes, you see parallel vessels, there are three conditions: TGA, CCTGA, and double outlet right ventricle. But if you don't see parallel vessels, then it could be truncus, the single artery, the pulmonary arteries arising from the truncus. You have an interruption of one artery, or one artery is atretic, whether it's aorta or it's pulmonary artery. So this is the differential of seeing just one vessel, one artery in a 3VT. So if you use a 3D frequently, then this is a very novel sign that you see a frog eye sign on a 3VT once you have a TUI in this section. Reverse boomerang sign is that you see the aorta coming from the RV, which the vessel coming from RV goes towards the right side and it is angled like this. Rather than coming from RV, the pulmonary artery, it would go on the left side. Okay, so this is called a reverse boomerang sign. Another sign is normally when you have a cross section of aorta and pulmonary artery, then what you see is you see a circle of aorta and you see the sausage kind of shape of RVOT and pulmonary artery, and that's what you see on the color Doppler. But in transposition of great arteries, you see both the circles, pulmonary artery and aorta, lying anteroposteriorly, and this is how it looks like. It doesn't form that circle and saucer appearance. That's another clue to TGA. So whenever in a disease where you have a lot of signs and red flags, you must remember that this disease is difficult to pick up and it's likely to be missed. As a policy, when you are examining or finished a fetal echo, you just finished one examining a fetal echo, what you do, you go back again and look for two things. One is a TGA, have I missed TGA? Two, you see TAPVC. So these two things you must keep in your checklist. Once you finish doing fetal echo, go back again, even if you finish, look for these two diseases because they can create a big problem in the neonatal period. Now, for a TGA, because you understand the deoxygenated blood remains on the systemic side, and there is no communication between saturated blood and a desaturated blood, right? So what it causes, because there is no oxygenation going to the body, then you get a severe cyanosis and acidosis, provided there is no mixing. If there is a mixing by an ASD and VSD, you are kind of reasonably saved. And in case there is no ASD or VSD, what do? You maintain ductus this thing for some short period. I mean, the opinions are divided here, but the best thing what everybody says is that do a balloon atrial septostomy. What does that mean? When the child is born, immediately the child goes into cyanosis and the balloon atrial septostomy would be required within hours of the birth. So delivery has to be done in a tertiary care unit. You don't have time to shift the patient at that particular moment. Now, balloon atrial septostomy, you put a deflated balloon across the fossa valis, you inflate it and pull it with the tug so that you tear the intraatrial septum and create a large ASD so that the mixing of the blood can happen and some oxygenated blood can go to the body, and that's how it helps. And this is how we do it. On the angiogram, you can see it. we put a big tug, and with the tug we tear the interatrial septum, and this could be a life-saving procedure for the neonate. How do we do corrective surgery? We do a corrective surgery, we actually do a switch operation. The distal part of the arteries we switch amongst each other. We divide pulmonary artery in aorta and we switch them on the other side. And once we switch those, obviously the coronary arteries which are arising from the aorta, they have to be transported. They have to be cut and shifted to the other side, right? This procedure should be done within a week or within 1 month of the birth. And in case the 1 month passes, then the LV actually regresses, because LV is pumping the blood into the lung, which is low pressure. So then in this situation, the LV regresses and becomes difficult to do a switch operation later. So the surgery in a TGA, one is that urgent situation where a ballooning could be required. Two is that the surgery would be required within a week or within 1 month of childbirth. This is what you are going to counsel the parents. So now, because of this, you should know certain bad parameters of transposition of great arteries. I'm going to show you one by one. Now, this is a patient of TGA, and you see a large VSD here, but that's not worrisome. Worrisome is small aorta. If you have aortic hypoplasia or aortic atresia or a coarctation of aorta, that's a bad sign for repair of transposition of great arteries. Second, again, if you have a VSD, which is a large VSD on the outflow and it extends into the inflow, this is the inlet VSD, which is extension from the outflow. With such a large VSD, it is going to put a surgeon's job in a difficult situation. Then you have a pulmonary stenosis. Okay, once you have a pulmonary artery which is small, that's the VSD what you have, and you have a VSD, aorta size is fine, the PA is small, the TGA with VSD and PS again is a difficult situation, because we may not be able to do a switch operation which is ideal. Another patient with the pulmonary artery smaller than the aorta, you see one VSD here, you see another VSD at the apex, and you see the third VSD large in the interventricular septum in the mid portion. So this again is a situation where switch operation may not be, which is an ideal, may not be possible, and what we need to do is a second best surgery in this, which could be a Restily. There are more like this surgeries, but they are not ideal surgeries to have, and repeat surgeries are generally required. I think because of lack of time, I'll stop short here, and maybe sometime down the line, if I get an opportunity, I'll tell you about DORV and truncus and other conotruncal abnormalities. So right till then, I hope I've done justice, and not only you, I have also learned that I still have to lot to learn. Thank you very much for your kind attention, and I can answer any of your questions.